Welcome to the DNA Talks podcast, where we take on the mission of unlocking the code of your genetics. This season is all about you, upgrading your health, not just on the surface, but down to the root cause. Join us as your clinicians at the DNA company investigate your DNA and beyond. The intention of this podcast is to enhance your lifestyle by changing what is in your control. This does not substitute the medical advice given by your personal doctor, therapist, and other healthcare professionals.
The question is to what is the underpinning of that infertility? Is it toxic stress? Is it emotional stress? So many studies go on about when
The
you're hyper
emotional
focused on it.
stress is the
Cortisol elevation,
inflammation.
of course.
Yeah.
Right.
Anything that drives the cortisol up there. And just think of everybody's exposed to stress.
Of course.
I mean,
and I want folks to hear from you as well, a little bit more about these non-thinking cells. You mentioned astrocytes, and of course alluded a little bit earlier about glial
right.
cells, but they don't necessarily think. That is to say, nerve to nerve communication, to emote and have a
Right.
feeling and or a memory or a logic or whatever you want. But they're non-thinking cells, but they're so important. And when they're dysregulated, the thinking cells get damaged, and then Alzheimer's, so what's that story?
Well, I alluded to the astrocytes that when they're in a healthy state, their key job, is to make sure that the products that are in our circulation, general circulation, don't get into the brain. And that's called the blood-brain barrier. And they're responsible for making sure that the blood-brain barrier cells are held tightly together. And only certain kind of things that we take in, like your DHA, your EPA, your alpha tocopherol, your quercetin, your zinc, all these things can get in, transported in, or testosterone can flow in. It's an ionic gradient that allows it, gradient that allows it to get into the brain. So the astrocytes also generate supportive chemistry for the neurons, which are you call them the thinking cells, okay? And the astrocytes are delivered to it. They take the glycine and the neurotransmitter building blocks. They make sure potassium is removed. They remove some of the garbage, and they interact with what you talked about earlier called the glymphatic system. The glymphatic system, like the lymphatic system below our neck, is responsible for removing toxins, fluids from our tissues down below the neck. Well, it was in 2017 that they discovered in humans that there's this glymphatic system, glymphatic for glial cell lymphatic system, which helps to remove excessive fluids, toxins, free radicals, damaged cells. It helps to remove the garbage. It's the garbage removal system. It's the dump truck of the brain. So there are astrocytes, there are pericytes, there are oligodendrocytes. Oligodendrocytes are the cells that are responsible for making myelin. So when you have a myelin destructive illness like multiple sclerosis, number one, Alzheimer's disease, ALS, and Parkinson's, what happens is you lose the myelin. So cells, we use the term, they short circuit. They don't function as well. Well, it turns out that things like pregnenolone, allopregnenolone, and pregnenolone, progesterone 2 will stimulate, and DHEA will stimulate the oligodendrocytes to make myelin. And in the video on our 6th case of reversed multiple sclerosis, we talk about the importance of DHEA. In fact, if there's
we're going to put that in our show notes, by the way. That's a great YouTube video, learning video for clinicians to pay close attention to as well.
It was great. And anyway, Tim's living a full life now after, a year in remission. Still monitoring him. But anyway, so these supportive non-thinking cells, as you called them, are important for making sure that the environment is neuropermissive. It allows the nerves to function at an optimal level. And one of the things that happens with inflammation is it alters the way that calcium from bones, calcium is an incredible neurotransmitter, specifically for this process of learning, memory, recall, the hippocampus, in these receptors called NMDA. There's a chemical called calmodulin that helps to allow the calcium to get into the cell. And when you have inflammation, too much calcium gets into the cell and leads to hyperreactivity. And that's the panic attacks, the agitation, the aggression that can occur.
Of
And
which alcohol is a huge culprit.
Oh, absolutely. I mean, I've cut down my alcohol from a bottle of scotch a week to a bottle every couple of months now. You know, fortunately, before it was with son-in-laws helping me to. Now I stopped.
Where do you live? A single malt Highland, or what's the
Balvenie usually. Balvenie.
Okay.
Yeah, it's a
Nice.
good one. So it's
Yeah.
a great one.
I don't
Anyway,
like the peat or the mosses as
no,
much.
the Lagavulin and the Lefroy are horrible.
A little bit
Are
too,
not
yeah.
horrible. They're not my palate.
Yeah, they're not mine. They're not mine
No.
either.
That's it.
So-
Lagavulin 16 is probably the mildest one, but I found one from India, Amrat, that is phenomenal. It's got the nose of the peat, very subtle, but none of the flavor. Amrat.
Like Dalwhinnie or
Dalwhinnie, yeah.
kind of.
Dalwhinnie.
You know what's interesting is we're talking about lymphatics, by the way. Some of the worst components.
Alcohol.
I love Scotch as well, but it's alcohol, obviously. But some of the
Right.
congeners that go into the barreling and fermentation, obviously, some of these toxins. That anyway, we're digressing, but we've covered so much so far in terms of and we can spend hours on this, but we've nonetheless, we dove into a little bit about the pre-hormones,
right?
Master hormones themselves. So the sex steroidal hormones, thyroid hormone, vitamin, minerals, of course. But I want to ask you about peptides. I mean, obviously we talked about IGF-1 to aid in brain repair, and these, help regenerate brain tissue, and they're testable. But so what I want to ask you is why you caution against relying, solely on synthetic hormones, because you've alluded to it, but haven't necessarily been, because it's important people understand their genetics, how they're predisposed, and then get some testing like this extensive, hormonal testing Dr. Gordon teaches about. But you've also been an advocate of BPC 157.
Correct.
So what are peptides about? And then again, why do you caution against relying solely on synthetic hormones in particular for brain treating?
Peptides are short chains of amino acids, and they have been developed or discovered based upon longer proteins in our body. For instance, the BPC 157 comes from a decapentapeptide out of the gut. What does that mean? It's a 15 amino acid protein that's in the gut. And what does it do in the gut? It helps the lining of the gut heal. So if you have gastritis or you have erosive gastritis, hyperacidity that leads to tearing down of the very small lining of the gut. Alcohol does that. Aspirin does that. Non-steroidal anti-inflammatories. Stress does that. A whole bunch of things just want to tear down the protective membrane inside the gut. So BPC 157 was developed in the 80s out of New York, I think it was. And what it does, if you inject it, it helps with tendon and ligament recovery, repair, which is really bizarre. It's a gut-derived thing, but when injected, it's a piece of it. BPC 157 is a short segment. I think it's 7 amino acids on it. From this longer one, I think it was 39. No, that's ACTH. But anyway, the BPC 157 helps with tissue recovery, specifically ligaments and tendons. And it's being used quite a bit in sports players. I mean, there was just an article about it where for rapid recovery. So BPC 157 is a great starting point, but it's not the finishing point. If you have someone whose livelihood is based upon their ability to move their limbs, articulate, their arms and shoulders, baseball, running, football, whatever, you need to back it up with other things like thymosin 4 beta or thymosin 500. Thymosin 500 has improved vascularization, angiogenic. So in order for an area to heal, you need to do what? You need to have good blood flow to bring in nutrients, to bring in chemistry, to bring in amino acids to build and replenish what was torn or damaged. And you need oxygen in the tissue. So the BPC 157 is help with ligament and tendon. You need to have better blood supply. It also upregulates the mitosis of the cells, the quality of replication, and also hits inflammation. I mean, some of the reasons why you can't repair is because the inflammation there is impeding,
So chronic.
inhibiting, blocking healing. And then the last thing, which we add in our orthopedic cases, is the IGF-1 LR3. Why is that so important? Well, it turns out that IGF-1 that our body makes, and I'll tell you the difference between the two shortly, it upregulates protein synthesis. It specifically helps in the manufacturing area of our cell called the ribosome. It upregulates the 4060 subunits or 4070 subunits to improve their ability to protein synthesis. And when you have a damaged area, what do you want? You want rapid regeneration of tissue. And that's why young children, when they cut themselves, so they injure themselves, they heal so rapidly because they've got optimal levels of all these IGF-1 and growth factors. And as we get older, we lose that capacity to make them. And then the difference between IGF-1 that our body makes and the IGF-1 LR3, the injectable one, is that the one our body makes, it's 8 to 10 minutes is all it lasts. That's the half-life, 8 to 10 minutes. You multiply by 7, so it's 56 minutes to 70 minutes, and then it's gone. The LR3 lasts for 18 to 20 hours half-life. So it lasts for a long time. So in our protocol, we don't use it all the time. I mean, use it consistently because it has such a long half-life. You can use it shorter and in conjunction with the BPC and the thymosin. So those are—
Is that LR, out of curiosity, long release? Like, what's the?
Yeah, LR3. It's a amino acid substitution,
Okay.
and it changes the degradation of it, so it lasts longer. Okay.
Got it.
IGF-1 binds normally. IGF-1, insulin-like growth factor 1, binds to IGF-1 binding protein 3, but there are 7 different binding proteins, which is another important story. Binding protein 3 and 4 are anti-cancer. So by having good levels of growth hormone, you have good levels of these binding proteins. The cardiac world learned years ago that IGF-1 binding protein 1 protects the heart. 2, anti-diabetic, anti-adipose tissue generation. 6 is neuroregeneration. 5 is bone regeneration. 3 and 4, as I said, is cancer. So they each have some really good benefits. Now, the question you had asked relative to why I don't use testosterone, generally speaking,
and in particular synthetic, right? I mean,
I don't use this. Yeah, I don't use synthetics because what I do is try to first fix the person's system so that they can make their own hormones, so they're not dependent upon an injectant, a cream, a whatever, a pellet, or what have you. So the 2 that we've been able to help, or really 3, thyroid inclusive, is growth hormone, and we use secretagogues, which are amino acids. There's a group of amino acids which turn on ghrelin, leptin. There's a population of components or products which are synthetic. Who was it? It was not Eli Lilly. It was Pharmacia, who makes growth hormone. They did the research and they found that there's a receptor which will accept almost anything to turn on growth hormone. And then arginine blocks the production of the stop making growth hormone product called somatostatin. So there are natural things we can do. So we use that. The first thing we do is drop the inflammation, correct the hormones, because hormones help to drop the inflammation. And we monitor them for 3 to 6 months. If they are able to restart their own system, We don't need anything. We just finished with a 56-year-old major out of Fort Hood, Texas, who was on 8 medications and not doing well. 6 months on our protocol, he stops everything. He continues to make his healthy levels of testosterone, which he wasn't making before, and he's off 8 psychotropic medications or 8
Wow.
medications. And he was sat in front of the a committee in Texas because we have a bill in Texas for a research project for the program that we have. So
Right.
anyway, so it's being reintroduced.
Well, that's incredible work. I mean, what you're doing is really vortexing, game changing. It's amazing, and I don't think enough people understand how important it is to get the full picture. I mean, that's really what we're talking about here. Really spending the time. Your health, as we like to say at the DNA company, your health's an investment, never an expense. But people
Right.
stop short and they think, even if the latest literature, like again, even more recently around the Women's Health Initiative, just sort of reapproved hormone replacement therapy. I mean, the wrong kind. We shouldn't be giving a synthetic estrogen, but if there was money from somewhere to test for bioidentical hormone replacement therapy and estrogen in particular, I think what they're already starting to see is that in the right individuals, once you've understood and also treated brain top down, estrogen balanced is actually probably reversing Alzheimer's.
Correct. There are 2.7 million articles that correlate estradiol and Alzheimer's disease. One of the most important things, you started the program talking about our mothers that have, the Alzheimer's. My mother passed. She developed her Alzheimer's, which is called statin dementia. And that is because by lowering her cholesterol levels so low that cholesterol is what protects you from Alzheimer's, as well as it is the precursor to all those neurosteroids in our brain and all the steroids below our neck. And she was
It literally is the ingredient your body needs to manufacture
Yeah.
hormones and brain hormones, right? I mean,
Okay.
it's the starting block.
You know what the dry weight of cholesterol, what percentage of cholesterol is the brain? It's 25 to 30%.
Is it? Yeah, I was going to guess somewhere around 15, but okay, even more.
Yeah, 25 to 30% of the brain is cholesterol. So the question is, because every membrane, every neuron membrane, astrocyte, oligodendrocyte, everything, and also the oligodendrocytes, the astrocytes, all the glia, the neurons, they all use cholesterol to make their own hormones.
Right.
In the presentation, I have a slide that shows what hormones are produced from cholesterol in each of the cells in the brain. And when you block the ability of the cells to take cholesterol, because it isn't there, and make the hormones to run their necessary functions, you take away. So, one of the unique things was that in my mom's case is that she lasted 8-9 years, which is unheard of in a traditional Alzheimer's case. She lasted a lot longer, and they kept on saying, "Oh, it's Alzheimer's." No, it's not. It's statin dementia.
Right. And my mother's there. And if you look at, some of the classification work, as I was alluding to earlier, that Dale Bredesen's put together, she's this hybridization of glycotoxic and neurotoxic. She grew up on a seed farm. So in the UK, a lot of pesticides early days. Yep. And of course, carries the ApoE3/4 variation, which again is not everything. There's that's my mom's backstory, but she was physically as healthy as a horse. So her unfortunate state of affairs is that she's outlasting her body is far outlasting her brain. She had that end stage diagnosis about 6-7 years ago now. So it's just terrible. We've got to do better. And we have to know and understand some of these. By the way, just, go ahead.
One question about your mom. Did anybody ever do a comprehensive hormonal assessment?
Oh, yeah, we did. I mean, if you consider, a serological workup on top of a Dutch, because that was all we were able to do in terms of sampling.
Yeah.
So yeah, and plus I have her complete DNA 360, so I know from where she comes. She's an interesting, when we talk about sort of hormonal classification of the genomic pathway. She's what we call a co-dominant female, so she's both got estrogen dominance and androgen dominance in terms of the pathways. What does that mean? That means she's quite quick from the aromatase perspective, but she also from the 5 alpha, she's very fast to make DHT as
Right.
well, and doesn't necessarily clear with the glucuronidization pathways, UGT, 2B17,
Right.
2B15, then some of the cytochrome P450 just to clear it as fast. So she kind of retains her testosterone. And then downstream, she makes a lot of 4 and 16 versus 2.
Okay.
And her detoxification, glutathionization, and calm to the
Yeah. So
besides what it does in the brain, she's not clearing. So part of this is hormonal, but I believe wholeheartedly that if she wasn't exposed to those pesticides, and by the way, she's also atypical. She never got developed type 2 diabetes. She just had a very high riding A1C. So with all of that, and again, it's never usually not a needle in a haystack as you were
what
describing.
was your insulin level? I mean, this is one of the things I see quite frequently in our patients coming in from other doctors is that they'll do a fasting blood sugar and they'll do a hemoglobin A1C, but they'll fail to do insulin. We to
Right.
date have reversed 39 cases of type 2 diabetes. They all were insulin resistant type 2. And the only way you know if it's insulin resistant is by doing insulin. They don't do it. So if your hemoglobin A1C is elevated, that might mean that insulin is non-functional. And the number one cause for that is chromium deficiency.
Right. Yeah.
Okay.
So her
And that's
insulin,
how we fix it.
her insulin was, so there's a number of things I looked at. And by the way, might as well just get it out. If somebody's going to do the appropriate, let's even sort of refer this as comprehensive cardiometabolic profile, because it kind of bleeds
Right.
over to the cholesterol, phenomenon you were describing. It's total cholesterol, but more than worried about too sort of high or high normal, we want to make sure it's not too low. HDL, LDL, VLDL, oxidized cholesterol, right?
Right.
LP little a, which are very, very familial. It's hard to drive that down, but oxidized LDL, ApoB, these are manageable. And then you get into the inflammatory factors we've been talking about: cytokine proliferation, imbalance in IL-6 and IL-1 beta, and TNF alpha, and too little IL-10 and all that stuff. That's immune modulation. But PLA2,
You're talking my
right?
language.
Yeah, homocysteine, PLA2, high sensitivity C-reactive protein. But then the insulin, right? The insulin can be too low or too high, right? And that tells a story. Leptin, adiponectin, the ratio, cystatin, all of that stuff should be looked at on top of the whole sex steroidal hormone path. I know you
Right.
have what is it again? 39? I can't remember how many you look at in
We
the,
look at 28.
28. Okay.
28, but there are also patterns where they look at 2 together, 3 together, 4 together, thyroid's 5 together.
Right.
So there are a multitude of interactions. And, I do it manually, but, I'll be 72 in January. And
Unreal.
I'm waiting for a little bit of my memory to start fading. So that's why 10 years ago I started writing the program in case my Alzheimer's catches up to me, or something with function.
Can I hold you honest for a second?
Sure.
Do you mean manually or do you mean man alley?
Any
Because I
which
know
way
how
you
much work
want
she's doing.
it. Yeah. Oh,
How,
Allison. Yeah,
yeah.
Allison's doing great.
And
She's
by the way, are you a granddaddy for the second time? Has that
uh,
happened yet? Or
twice. She's going to make it the third.
right?
She's
No, three.
due the 9th, 10th, or 11th. She's due.
So it's upcoming.
So it's pretty close. So she's technically on maternity leave right now. So it's left me with not only my military caseload, but also with her private, her civilian caseload, which is
Oh
fine.
boy.
A lot of the ones that are with her civilians were my original, and they were good enough to allow me to transfer so I can do the focus on our military. One of the things I will like to say is there was just a study that came out talking about the use of intranasal pregnenolone.
Mm.
Okay. Why? In Alzheimer's disease, you lose in the frontal lobe, where executive function, frontal lobe dementia, where it's pretty bad, you lose pregnenolone, pregnenolone sulfate, the active form, allopregnanolone, allopregnanolone sulfate, pregnenolone, progesterone, both sulfonated and non. You lose it in the front. So what is the importance? Pregnenolone's been found to upregulate in 4 key areas of the brain acetylcholine. So you can get a rapid response. And the study, I'll send you the study, as well as I'll send you a copy of my pre-release.
We'll put them in the show notes as well. We'll have links to these for everybody to look at.
Okay, fine. But it's important that we look at, you talked about the estrogen pathway, or the pregnenolone to DHEA that takes you down the pathway to all the 3 estradiols, the testosterone, and so forth. An important pathway is the left pathway, is what I call it, where it goes from cholesterol to pregnenolone to progesterone, pregnenolone to allopregnanolone to cortisol to 11-hydroxycortisol to aldosterone. This pathway here is being ignored, and that's the one that helps to stimulate the repair in Alzheimer's. With acetylcholine, stimulates the production of myelin from oligodendrocytes. Progesterone in and of itself has an anti-inflammatory component to it.
Right. I'm so happy you mentioned that.
Yeah,
that's so important.
Yeah, fluid modulation through the lymphatic system. Right. So we're missing a really strong look at the left side when we're looking at the right, the testosterone, the DHEA, the androstenedione, and the estrone.
And the big takeaway, and the big takeaway here is that this is something we can intervene on quite naturally. When we talk about bioidentical hormone therapy, I think one of the things we're both agreeing on to drive home here is that doesn't stop at estrogen, progesterone, or testosterone. It's not just the upstream either. It's these intermediates, right? The pregnenolone, DHEA, which are basically hormones that are available over the counter at your local health food store supplementally. I don't recommend anyone, by the way, start taking any of these things without, proper oversight by a physician. One that's trained in functional medicine can test you and know what you're doing. But always advocate also first knowing your genetics. I wholeheartedly believe that this speaks volumes to what we can and should intervene with. By the way, I don't know if you knew this yourself. You talked about EGCG and quercetin. These are so dose dependent. Too much, and you're actually dampening glucuronidization. Too little, not doing anything, you're pixie dusting. But upregulating is a fine tuning of dose dependence, right? And the same thing, by the way, downstream and management of detoxification. So, knowing genetics is empowering because it's your personal instruction manual as to how these hormones are regulated and the speed at which they are converted, and the intervention might be better qualified given what serology is giving you lifetime. Hey, are you into doing some fun rapid fire true false before we sign off?
Sure.
So this is me asking a question, true false, and you answering. You can extend on it if you will, but this also helps to get the message out there to social media in soundbite form. All right.
Okay.
All right. Here we go. True or false, Dr. Gordon, hormonal imbalances are just as common in non-traumatic brain injuries as they are in traumatic ones.
True.
True or false, high levels of cortisol are always harmful to the brain.
True. Fractalkin.
True or false, pregnenolone is the most abundant neurosteroid in the brain.
False. DHEA.
And you're mentioning in the prefrontal cortex, right? It might have allocation.
Right. In the frontal, yeah.
True or false, growth hormone is universally recommended for anyone with cognitive decline.
False.
It should be, maybe.
It should be. Absolutely.
Right.
I mean,
right.
Absolutely.
True or false, testosterone replacement can help reverse cognitive decline in all men with Alzheimer's.
False.
True or false, genetic testing may help to determine certain risk for hormone-related cognitive decline, in your opinion.
Absolutely true.
True or false, BDNF levels usually decline with age, but targeted lifestyle interventions can actually help reverse this.
Yes, to a degree.
And that
If
caveat, especially for those with TBIs, MTBIs, traumatic brain injuries, and so forth, to give them some hope, is what? What is the caveat there?
Well, high impact interval training will help it. High impact aerobics will help it. Nutrition, staying away from some things. Also, cold plunges
Yeah.
will increase your cold shock proteins, which increase your brain derived neurotrophic factor. So, getting companions with your tonsils, if you're a guy, has some benefits in the brain, the other brain.
I've
Okay.
also heard, and I'm pretty sure you appreciate the literature around saunas, the opposite, getting very, very hot,
Yeah.
upregulating BDNF. And here's what shocked me, actually, some of the epidemiological studies and even just sort of reviews of state of happiness, within country cohorts. So compared to vitamin D, by the way, as you also know, increases BDNF indirectly. But these happiness indexes that scientists have looked at of those individuals who live north of 40 degrees, where there's not a lot of sun.
Right.
So SAD level, as seasonal affective disorder, and it turns out that the Netherlands, who, by the way, the point being, have a 1.5 sauna per capita. So it turns out BDNF's related to mood, and upregulating it also actually makes us a little happier. They don't get sun, probably low in vitamin D, the majority of them, but they report as being the happiest people on the planet, probably because they're doing saunas every day.
Hey, have you been to Amsterdam for any length of time?
I have.
More than 6 weeks?
No,
Okay.
but it's dreary.
I was there at 18 for 6 weeks, and you believe it, it's the happiest place on the planet.
Oh, that way. Yeah, sure. Yeah. No, it's an interesting, very happy-go-lucky. Again, you would
Great.
expect the opposite, but these individuals. Oh, by the way, and it's also in the literature that they have downregulated BDNF. They are AG on average. You want Gs, the more Gs, but they're AG, right? And these individuals have downregulated brain-derived neurotrophic factor genetically, and yet they're the happiest people. Anyway, must be the saunas. Lastly,
Yeah.
true or false? Methylation. Didn't talk a lot about it, but of course it's sort
Right.
of almost synonymous with inflammation. Is maybe more important than detoxification when addressing neuroinflammation.
It's a complex one. You saved the best for last.
I did. It's tricky. I don't know that there is a right or wrong or a true or false answer to that, but it could be.
I
Maybe you
split it
want to.
down the middle. I'd say sounds good. Sounds good. Okay. Because if you look at where the methylation, because we talk about, MTF, we talk about folic acid, B12, there are other systems that we totally are not talking about. And what's that? Their impact on the inflammatory cascade. Any product that is not processed, metabolized to its ideal can be perceived by the body as a foreign agent or an irritant, and that irritant will increase the inflammation. So, is methylation generically harmful to the brain and function? Absolutely. I see it as you see it with crazy mood issues or symptoms of hand or gut or yeah, we see it.
I look at the DSM every so often, and as it went from 4 to 5, and
Right.
I don't know, I read through that sometimes as neuropsychiatric diagnostics. And when I do my differential diagnosis, I'm like, methylation, hormones, methylation, detox. Anyway, treasure trove of information as
Yeah,
always.
I got three questions for you.
Okay.
It's really for your populace, and these are relatively new numbers. If you were to guess, and that's all this is going to be, if you were to guess at the percentage of veterans that have dementia after a TBI, you would say what percentage?
After a TBI, okay, let me qualify the
Yeah,
question by
after a TBI.
have they had a previous single TBI, and is this secondary or is it?
This is a primary.
This is
Okay.
primary because I am
Oh, well,
familiar.
let's do a little better. It's repetitive, subconcussive, repetitive head trauma. Because in the military, you're always exposed to stuff, and that's one of the problems with the DoD, Department of Defense, and the VA is that they look at things singular. They don't even ask about what activities the individual was doing before they enlisted in the military. My partner Andrew Marr from Warrior Angel Foundation, he was a football player from birth, okay, until he finished his college and ended up in 9/11, because of 9/11, enrolling in the Green Beret in the Army, ended up in the Green Beret.
Right.
So
Well,
all with multiple. So I'm going to have to default and say multiple subconcussive traumas.
okay. So then it's a little more educated guess. By the way, I'm guessing, but I
Right.
am
This is
familiar.
wrong guessing.
I
This is
am
new information.
familiar with. I think it was 21 or 22 in JAMA neurology
Yeah.
that certain vets had, again, with a history of TBI, were something like 50 or 60% more likely to develop dementia than those without the TBI, right?
Okay.
So I don't
No,
know, maybe 10, 15, 20% of
well,
vets
it's
could be
12
living
to
with dementia.
30% dementia veterans with TBI. What
Wow,
do you
still
think
it's
the
high.
Alzheimer's occurrence rate is in veterans who have had repetitive head trauma throughout their service? What percentage of them develop Alzheimer's?
When it comes to, yeah, specifically, and again, what we have to ask the question is well diagnosed Alzheimer's, right?
Diagnosed Alzheimer's by the DoD Veterans
Okay.
Administration.
So I don't know, two times the risk, maybe. So like
Yeah,
percentage, maybe.
60%. 60,
Yeah,
60.
crazy.
Last one.
Wow.
Parkinson's disease, because Parkinson's, Alzheimer's have the same foundational issues with tau protein. Even more so is the inflammation affects the glutathione reductase in
Right.
the dopaminergic cells. So you specifically damage your ability to make, and that's peroxynitrite that does it. So we have a product coming out which will block the peroxynitrite that causes insomnia, migraines, a whole litany of stuff. So Parkinson's is 56 to 83%
Wow.
veterans
I was
with
going to
T.
say, and then obviously you have to factor in like what pest, like what was the pest side again? Agent Orange.
Yeah, Agent Orange.
Yeah, and
I don't
how
know
that.
what, other than Agent Orange and Vietnam War, I don't know what its specific chemical name is.
Right. But anyway, one thing we find consistently, because I'm not Parkinson's, although is somehow more and more popularized beyond a movement disorder, neuroinflammation, neurodegeneration, your whole area of expertise and focus. Here's what we see at the DNA company. We see this trifecta in Alzheimer's as well, in most chronic fatigue, most Lyme disorders, and
Right.
anyway, it's this
Inflamm-
trifecta.
yeah.
The trifecta is poor methylation. And when I say poor, I just mean there's areas in which can be modulated or improved upon. But if methylation is like a relay race, boy, is this anchor dropping the baton over and over. So there's poor methylation. Detoxification is typically expressed as dual null variant, meaning their GSTT1, GSTN1, and even GSTP1 are null. They don't carry the copy numbers that, mom's supposed to give them some instruction, dad's supposed to give them some instruction on how to detox. They have neither. So
So
poor
what do you think
detoxification.
happened?
Once
What do you
again, like
think
the
happened?
ApoE gene, this was evolutionarily to some degree benefit, right? So when there was
Oh,
a null
gotcha.
variant, but now obviously with the bombardment of toxins and of course subclass neurotoxins, if you're dual null variant with poor methylation, and I was going to say hormonally, what we most often see is whether it's male or female, that estrogen dominant state, right? So that high, 4 and 16 hydroxyestrogen production with, again, downstream poor compt, poor detox. So that's in Parkinson's, that's typically what we see.
Okay. And the third?
The estrogen dominance, poor
Oh,
detox,
estrogen
poor
is the third.
methylation. Yeah. That would be the third. Male, because that's a pro-inflammatory, and that's why I think synthetic. You tell me, you're the expert. Synthetic estrogen is fuel to the fire.
It absolutely is horrible stuff. You know, absolutely horrible. Any of the synthetics, the 17 hydroxy progesterone,
Right.
not good. Synthetic
Right.
estrogens, not good. But they have bioidentical, pharmaceutically manufactured estrone and also progesterone, which is good. So we only use compounders that use the pure plant-based um, origin products, not
Right.
chemically manufactured.
And then at
Just
some point, maybe in the future, we'll have you back on. We'll talk about oral versus topical delivery systems. It's a whole ball of wax in itself. Where can people find more about you and your initiatives and talks that are coming up, and specifically also where people can get tested once they have their DNA? Where can they learn more about this 29 point protocol?
28,
28.
28, 28. Let's see. My educational site is www.tbihelpnow.org. And if they go into the science, they'll get a lot of the current papers that I've had published, and other people that I've learned from, a lot of them that I've learned from. I mean, what I do has been based upon the brilliance of all these researchers that came before me. The only thing I did was I read and put it together into a comprehensive protocol. So there's where you can get some education on some of our treatment protocols, on our annual report of our veteran outcome and our civilian outcome. And then there's under the media, there's our first discussion, I believe, is up there from years ago. And then there are other projects with the ESPN, with some of the television programs. And then if anyone's interested in getting the labs done, they can go to our millenniumhealthstore.com and acquire the laboratory testing. In Canada, we've trained a number, about 8 or 9 docs in Canada. There's in Toronto, there's in Whistler,
Oh, in
snowboarding
BC. Yeah.
in BC, and Vancouver, a couple of dock in Whistler and a dock in Toronto. And I was just invited to middle of next year to go and give a program for traumatic brain injury and the work that we do. I'll keep you posted
Yeah,
on.
please do.
Those
I
are
appreciate it. 95% of our followers are US based. The company is now actually based in California, Norco, so not
Norco,
far from yourself. But I appreciate that. Yep, there you
400
go.
miles north. Yeah,
Right.
yeah.
I so appreciate you, Doc. And for everyone else listening, that wraps up today's incredibly enlightening conversation with none other than Dr. Mark Gordon. And if you've ever wondered how your hormones, your DNA, your brain health all interconnect, I hope that today's episode gave you some of the tools to take action. So don't forget to subscribe. Of course, share this with anyone who needs to hear it, and check out Dr. Gordon's research at tbihelpnow.org. Until next time on the DNA Talks, remember, your health is an investment, never an expense, and your health starts in your genes, and your future is in your hands.
Beautiful.